So, good morning, friends, and happy Sunday. Now, in 30-40 minutes, we will discuss about fluid and electrolyte management in newborn. And this is the very important basic topic come in our day-to-day life. There will be some questions and also answers. So, it will be awake to you. My first question, what is better, fluid or nutrition? What is better, fluid or nutrition? So, here our answer will be nutrition. Nutrition will be better rather than giving the plain fluid to the baby. Now, if we say that which type of the nutrition is better or safe, so always enteral nutrition is always better. In enteral, breast milk is always good. MOM means mother's own milk that can be express breast milk or that can be donor pasteurized human milk. Then it comes to the second. Third come regular formula and any special condition then special formulas are there. If we are not able to give fluid in the form of enteral nutrition, then we can give fluid in the form of parenteral nutrition. So intravenous fluid with electrolyte, it's not a good idea. We should give some protein, some electrolytes, and some good amount of the sugar in the form of partial parental nutrition, or if possible we can give, if facility available, then we can give total parental nutrition. So why I am saying, because in this chart you can see this is the baby when delivered in hospitals. More premature baby is having the more problem. Often baby in ICU, this 28 to 32 weeks baby are survived, but over the period their growth is hampered and then they come less than 10th percentile in a category of failure to thrive or malnutrition. And it's very difficult to cover over the time. So, friends, if we are giving some sort of the nutrition, then it problem can be some percentage can be minimized rather giving IV fluids. And it is a critical emergency in case of the preterm babies. Why? Because not only the body is growing, but brain is also growing in this time period. So this is the answer. Always go with the enteral rather than parenteral or IV fluids. Breast milk is the first, mother's own milk or donor pasteurized human milk, it's a second. Then comes to the all formula. Parenteral, if possible, all the facility available, then total parental nutrition. Or we can give partial parental nutrition. If things are not available, then a simple IV fluids. Now, where we cannot give enteral nutrition. So, like extreme premature baby, less than 1 kg of weight. Here, we cannot give enteral nutrition. Definitely, we have to go through the parenteral. Now, if perfusion is poor or baby is having hypotension. Now, third is any surgical problem like rectal fistula, NEC, obstruction ileus, or feeding intolerance. So all these things are there where we have to give IV nutrition rather than oral nutrition. Here intolerance, it's a some kind of the things that is perceived variable by the variable person. I want to say still if can possible then give enteral nutrition with some prokinetics, or we can give in an infusion pump also slowly we can give, or rather than giving more large amount of the feed, small amount and frequent feed can be give to the baby. Now there are few more conditions where we have to give IV fluids, but all these conditions, namely asphyxia, small for date or IUGR, respiratory distress, convulsion, hypothermia. So all these problem we have to give very short IV fluid, or we can give IV fluid with minimal enteral nutrition. So in these conditions, like baby is having respiratory distress, 1.3 kg baby. Now baby settled on CPAP and baby vitals are good, perfusion color. We can start early feed. Convulsions now controlled. We can give feed and also respiratory distress. Once settled, we can give feed rather than fluid. IUGR baby for a small time, we should be give IV fluid, otherwise we can go with the feed. Again, also this is common in hypothermia. Once it is corrected, we can give enteral nutrition rather than the parental nutrition. So here I want to say we can also give fluid in the form of feed. We can give also fluid in the form of some sort of parenteral nutrition. So always prefer. Now, how much fluid we should we give? Now it depends upon birth weight, category less than 1 kg, 1 to 1.5 kg, and more than 1.5 kg. Choice of fluid on day 1, dextrose 10%, and less than 1 kg depends upon blood sugar, we can give 5 to 10%. How much fluid we should we give on day 1? More than 1.5 kg, 60 ml per kg. Day 2, 80 ml per kg. And day 3, 100 ml per kg. 1 to 1.5, 80 ml per kg, 100 and 120 ml per kg. Day 1, day 2 and day 3 respectively. Less than 1 kg, 100 ml, 120 and 140. So why this change in fluid per kg in a preterm baby? This is the one of a question, and it's very important, very critical also. So it is basically, you can see in this figure, one axis percentage of fluid, other axis gestational age. So you can see that around 500 gram baby, they are having minimal, very minimal fat. Protein, though, they are having almost equal percentage. But because of this fat is less and intracellular fluid is less, so extracellular fluid is more in these babies. And this is up to the 1.5 kg almost. Then there 1.5 to 2.5 kg. That the significant amount, or we can say substantial amount of intracellular fluid is increased and also fat mass is increased. Hence, extracellular fluid is decreased over the time. So because extracellular fluid is high, 1 to 1.5 kg baby, that's why we have to give more fluid in these babies. Now, more extracellular fluid, more water loss, and more electrolyte balance. So we should be very, very careful in case of the very low birth weight baby. More premature baby, more immature organs, more extracellular fluid, and more insensible bone loss. Like preterm baby, they are having very delicate thin skin. We have to take care also skin, because skin sometimes very prone to damage also in these baby. So with this premature skin that having more and more extracellular insensible water loss or extracellular fluid loss, these are often are having problem of respiratory distress through lungs also. Substantially high fluid loss is there, and their kidney is not mature that much, so they are also having fluid with electrolyte loss through renal. So all these things lead to be they're prone for fluid and electrolyte imbalance rather than more than 1.5 kg babies. If we can say how much this extracellular fluid in adult 20%, newborn 40%, and preterm newborn about 24 weeks if we say it is around 60% of extracellular fluid in a preterm and 24 weeks it's very high 85%. Now I here also write loss. This is the usually extracellular fluid loss in a term newborn 5 to 10% in first week. Preterm that is the 5 to 15%. This fluid loss we should be allow in this baby in a preterm baby for some extent because it is very important for adaptation of transitional circulation from fetal life to newborn life. Again, same things in the diagram. One end, there is a fetal water content, body water content, other in age in months. So up to 9 months fetus and more than 9 months, obviously newborn and full term newborn. You can see here over the period, total body fluid, extracellular fluid decrease, but intracellular fluid increase. So in this preterm baby, not only we have to maintain this fluid and electrolytes extracellularly, but also intracellular we have to maintain cellular tonicity or osmolality. That we have to take care by giving balanced fluid and electrolytes. Now again, if we say less than 1 kg, then insensible water loss 90 to 100 ml per kg per day. 1 to 1.5 kg, that is the decrease significantly 40 to 60, and more than 1.5 kg, this is less 20 to 40%. So there is a range, means each and every baby is different. We need to be monitor all the baby for fluid and electrolytes and give fluid and electrolyte accordingly. Though I have written fixed amount 60, 80, 100 for 1.5 kg baby IV fluids in the previous slides. You can go in this previous one slide. Though here I have written this fixed amount, but it is not always fixed. It can be changed from day 1 to day 2, depends upon few criteria that we will discuss in a further slides. So what are those criterias? Let's see where insensible water loss is increased. If respiratory distress is there, if breached skin because of uncarefully removed adhesive tape, surgical malformations like gastroschisis, omphalocele, neural tube defects. Hyperthermia is also very bad for newborn baby. High ambient temperature, again increase. Radiant warmer and phototherapy, again increase. Decrease humidity surroundings, motor activity in crying. All in these conditions, insensible water loss is increased. Now I tell you what we can do to decrease insensible water loss. We should be managed optimally respiratory distress in preterm newborn. We can start from labor room CPAP, continuity CPAP, or appropriate ventilatory support in an ICU. Timely and safe surfactant will take care of asepsis, all these procedures. Use minimum adhesive tapes in a newborn and use some sort of the like tape. These are the Tegadum or skin friendly tapes if they are needed, and remove all these tapes carefully. This is very important for preterm newborn, where you need to do ET fixation, where you have to put probe for temperature, where you also need to put probe for saturation to check saturation pulse oximeter. And sometimes also required to put chest lead all these newborns. So removal of adhesive tape, that should be very important. I believe rather than putting ET tube, we can go with non-invasive more and a preterm babies. Need to be cover all these surgical malformation by appropriate covering, gastrosteasis, omphalocele, and neural tube defects. Always put body temperature, always put probe where it is recommended. These are the right hypochondrial and liver area in a supine position that has minimal movement, and it is also having very good supply of blood, and it's also almost keep information of core temperature, so that baby temperature will be maintained properly, and it should be very good type of adhesive, that it should not be loose, it should not be removed. Otherwise, radiant warmer will give more and more heat if it is the not properly attached to the newborn skin. Again, we have to see there is a more problems like high ambient temperature in a, especially in issues where AC is not available and ceiling fan are used. In case of the summer, this is the one of a problem. So that proper ambient temperature should be maintained in the form of the air conditioning and having good fresh air flow availability in an ICU. So take care also environment contamination of bacteria, virus and spores. Now come to the radiant warmer. Heater output is always monitored on the radiant warmer. If heater output is more, it means somehow temperature of surrounding is not maintained. Frequent opening of door or radiant warmer keep in a vicinity or in a air current of door window that is required need to be open, where so it always increase radiant warmer temperature. Nowadays phototherapy is a more friendly. Always use LED phototherapy. These are the cool light. They are having minimal insensible water loss. Humidity, try to maintain surrounding again with proper optimal air conditioning of room, or if can possible baby less than very low birth weight baby can be nursed initially days under the incubator rather than radiant warmer. Now for motor activity crying, these are often seen in a full term babies. Give some sort of like feed, or if baby are there and having good everything is normal, then try to shift to the mother side. All these baby that the crying can be reduced in the home also with the KMC. Non-nutritive sucking can be applied. So these are few simple interventions that we can do with all these babies. Now radiant warmer Again, I am highlighting here. Again, I want to say here to you all, always focus on the heater output. If your heater output is continuously high, it means either baby in a shock, baby is very sick, or baby is very premature. If can possible and facility available, then please use incubator, especially less than 1 kg babies. So again, same things that we have discussed. Use of incubator. Humidified gas we should be used in a CPAP, high flow nasal cannula and ventilator. Some sort of the heat shield or plastic coverings that we can be used if incubator is not available in the radiant warmer. Increase ambient humidity and some sort of the oil, ointment, or some sort of the gel that is safe for newborn can be used to decrease insensible water loss. Now we will start 100 ml per kg. How we can go? That is the day 6, day 7, day 8, 190, 170, 150. But I believe that your baby with your NICU safe NICU should be stable. And this 190, 170 or 150, it is by the feed, enteral feed rather than IV fluids are there. If surgical conditions are there, then carefully calculate protein, calorie, all these ratios and give appropriate protein calories and that the fluid giving by the IV fluids. It is taking care around 160 to 170, 150 to 160 ml. Not go with the more and more fluid and try to nurse all these baby if these baby are very extremely premature in incubators. Now day one fluid, that is the always fixed, but advancement of fluid, it depends upon weight. Excessive weight loss, yes, go with the day two fluid as per recommendation. If not that much of weight loss is there, having the physiological weight loss, then increase fluid with all these here, take care of the sodium. Hypernatremia, yeah, fluid need to increase. If sodium is normal and weight is not decreased, I believe that same or some sort of the fluid can be, some amount can be increased, not as required, as is recommended in the previously slide. We can discuss with our consultants. Sickness is causes SIADH and sometimes that the sodium it's not reliable. If baby is very sick, other things is the ultrasound based assessment of fluid also we can do it. Urine output. It's not that much of reliable in a very low birth weight baby that we will discuss. Your TPR chart, it is also helping the fluid and electrolyte management. So nowadays ultrasound, we can see this in IVC and their collapsibility. This is the formula. If it is collapsible more than 55%, then it's showing that we have to increase fluids. Other hands also we should we go and see for PDA. The PDA is there. Nowadays we can do it. Previously we need to help up pediatric cardiologist. Again that fluid management. Advancement of fluid should be very clear. Why I am saying that urine output is not deciding for fluid? Because less than 30 to 30 week gestation, baby pass large amount of the diluted urine despite of dehydration because of renal immaturity. That's why it is an unreliable marker in case of baby is very premature. That is your urine output. Baby dehydrated, but still baby passes more urine. Though it's a helping in a fluid management along with serum electrolyte, especially sodium, and change in a weight over the time. Again, the same things. Preterm baby concentration capacity is very less, 600, and in an adult it is almost more than 2.5 times. No weight loss in a term baby 1 to 2% per day, total weight loss 10%. In preterm baby 2 to 3%. And this is because of extracellular fluid is there. So no need of replacement up to 15%. Don't give extra fluid all these patients, but try to decrease extracellular fluid loss as we have discussed in the previous slides. But don't give NS boluses, other boluses and these babies. Now baby is day 3, day 4 old and weight loss is significant. What weight we should be take for calculation? That's the birth weight till newborn cross birth weight. Now some situation where we should be restricted fluid like RDS, BPD, PDA. In asphyxia that if SIADH renal injury is there then need to be restricted fluid, otherwise we can give normal fluid as per recommendation. Phototherapy, extra fluid. Nowadays LED phototherapy available, so no need to give extra fluid. And why we should we give fluid if baby is admitted for phototherapy? We can continue with antral feed only. It also improve enterohepatic circulation in the antral feed. So it decrease also jaundice and it also reduces risk associated with the IV fluid in the form of electrolyte imbalance and sepsis. Now, friends, do you know that in a fetal life, glucose supply for body it is around 6 to 8 milligram, 4 to 6 milligram per kg per minute. That we should be maintained during extrauterine life also. So here glucose is having the significance. This 4 to 6 milligram per kg per it's a GIR. So always in each and every day we need to calculate our GIR. But GIR not go beyond 12 milligram per kg per minute. GIR not go that lead to the neonatal hyperglycemia. Neonatal hyperglycemia, it causes glycuria and again it causes dehydration because fluid loss is there. So friends, daily calculation of GIR in a sick baby, it is very, very important. If baby are getting in the hyperglycemia, then reduces GIR up to 4 milligram per kg per minute. Still hyperglycemia is there. Then insulin will be help us to maintain GIR. It increases supply to the end organs, all the vital organ of the glucose. It also decreases glucosuria. But give insulin very carefully. Go with as per standard protocols. This is the formula that how to calculate GIR. So question here, what is the GIR in infants weighing 2 kg on a total fluid 120 cc per kg per day using dextrose 10% solution? Now go with the fluid. So 2 kg and 120 divided by 24, that is the 10 cc per hour. It's a fluid requirement. Now GIR 10 into 10, this is fluid rate and percentage, divided by 6 and to the weight. So it comes 8.3 milligram per kg. So this is the one of the simple things. Few more formulas are available when your glucose concentration is fixed if you are given dextrose 10%. One more formula that you can remember. Fluid requirement per kg per day into the concentration of dextrose divided by 144. Now, give only IV fluid, I say no. Also give amino acids. Depends upon your protocol. That can be discussed in another PPT. Also give some of the form of the lipid if that safely we can prepare it. And baby is stable. Daily to daily, we have to see readiness to give enteral feed. If possible, please start enteral feed as early as possible. And the advancement now evidence support 30-35 ml per kg per day we can advanced rather than 15 to 20 ml per kg per day advancements, and try to keep baby as early as possible on enteral fluid or enteral feed. So now fluid requirement, it depends upon weight, serum sodium, urine output, skin turgor, and friends, day one and day two, these baby skin is very premature insensible water loss. But over the period, skin one of our organ that rapidly advance, and around 15 days skin is as mature as adult almost skin in for the insensible water loss. So these are the few protocols that use different issue, how to give glucose, lipid, proteins. And thank you very much for listening carefully. And thanks to NNF to giving me opportunity.